Oh. Okay. You can do it. Okay. Does the kidney have innervation, sensory, and motor? Well, you know your kidneys can hurt, right, if you've ever had kidney infection. So it does have visceral sensory innervation. It also has motor innervation. The motor is autonomic motor innervation. And the autonomic motor innervation, the sympathetic nervous system controls blood flow to the kidney, and therefore a little bit of kidney functionality. It also has parasympathetic innervation, but nobody's ever figured out what it does. Like, it's wired up to the parasympathetic nervous system, but if you cut it, it doesn't change kidney function, or if you stimulate it, it doesn't change kidney function. So we don't know whether that's just like an evolutionary leftover, that it's still wired up, but it does have both autonomic and innervation, sympathetic and parasympathetic. Okay, so now what we are going to do is we're going to get into the microscopic anatomy and functionality of the kidney. And so what we said last time was the kidney's function is really to allow for exchange between blood and urine, yes? Okay, and we said that it was a similar sort of concept to the placenta, in which you've got two separate sets of tubes and you don't want to attach them, but you do want them snuggled up enough that they can do exchange. Yeah? Same concept as the kidneys, only instead of two capillary beds, we've got a capillary bed and then what we call a uriniferous tubule, or basically blood tubes next to P tubes, close enough that you can do exchange between them. We never want to connect them because last time I checked, if you don't want urine in my bloodstream, if I can avoid it, right? But we do want to snuggle them next to one another. The sites at which they snuggle are called nephrons. These are called nephrons. There's around 1 million to 1.3 million nephrons per kidney. So they are going to have lots and lots of surface area for exchange, okay? And understanding the structure and function of the nephron is really important for both A and P. So let's start talking about this function, and then we'll get into the specifics of the structures. Okay, so what we are going to have is a really curvy blood tube next to P tube or organization. Now, I'm going to straighten them out just so that you can get the terminology, and then we'll add in the anatomical details. But first, let's look at functionally what the kidney is doing. So we already know the blood tubes and we know their names, but we haven't learned the names of the P tubes. Okay? So basically what we are going to do is the kidney is responsible for cleansing the blood, yes? And changing the composition and volume of the bloodstream. Okay, so what I want you to imagine is, here's my metaphor. We are going to go into a house, the blood, that's so damn dirty, it's like a hoarder house, okay? And what we are going to do is we're going to do a 3-step cleansing, right, of everything that's in there. So, 3 different steps. Before we get into the specifics of the steps, let's define our tubes. They're curvier than this, but they're going to be 2 sets of tubes that are right next to one another. One contains blood, one contains urine. Ultimately, the blood came from the renal artery and will end up back in the renal vein, right? So it's circulatory. This one is not a circle. Blind end starts at the kidney, ends up in the toilet. Yeah? That makes sense? Okay, so wherever the blood tubes are next to the P tubes, in a nephron, we have the opportunity for exchange. We will see today that the exchange works really well because these tend to be relatively porous, right? So there's opportunities. Does that make sense to you guys? So what we are going to do to clean this hoarder house is we are going to do a 3-step process. The first step is really, really general. What we are going to do is there's so much crap in the house that what we do is we take everything that will fit through the door and dump it on the lawn. It's a really general pressure-driven transport mechanism. Do you guys remember from 1610, pressure-driven transport that dumps water and small solids, anything that will fit through the door, the holes, out. What's that transport mechanism? Filtration. Yes, it's filtration. Good. All right, so the first step is going to be dump everything that will fit through the door out on the lawn. Now, it's pressure-driven. Which of these fluids is dependably higher pressure? Blood. So filtration runs that way. Yes? What kinds of stuff do you filter out? It's very general. It's not specific or selective. Anything that will fit through the door. So one of the things you're going to lose a whole bunch of is water. You filter out about 47 gallons of water per day, but you don't pee 47 gallons of of water because we got some work to do. But what else do you dump? You dump waste. You dump everything out on the lawn because at this point you can't tell the difference from grandma's china, a box of money, another cat box, right? So you're just dumping it all. So you're not being selective about what you dump. So you dump water and small solutes, including ions, like sodium, potassium, calcium. You also dump nutrients that you didn't want to lose, like glucose. Like that's money, right? But you're not selecting through the things yet, you're just dumping. And you, of course, do dump waste as well. So you got the cat boxes, right? And you dump them out there. Does that make sense? Okay, so this is a really general dumping. But we ended up losing some things that we wanted to keep. We want to bring the money back in the house, right? Okay? So what we are going to do is the next step is very careful and selective. It's called reabsorption. Reabsorption is going to go out through everything on the lawn. It's not going to bring any of the cat boxes back in, right? But what's it going to do to grandma's china? Bring it back in the house. What's it going to do to a box of money? Bring it back in the house. If you had 750 cans of corn, that's too much corn, but maybe you'll bring 3 back into the house, right? That makes sense? So it's going to sort through, and it's going to bring back in most of the water, because you don't pee 47 gallons per day. And it's not going to bring back any of the waste, but it's going to bring back all of the nutrients that it can, because that's money. And it'll bring back ions as needed. So what do I mean by as needed? If I was calcium deficient, if I dumped it, I'd try to reabsorb all of it. If I had excess calcium, if I dumped it, I'd leave it out on the lawn, right? So by this mechanism of selecting what I bring back in, I'm actually regulating my blood homeostatically so that it has proper levels of things. Does that make sense? Okay. So now what we need to do is we've brought everything back into the house that we think we need, but now we need to very, very carefully go through all of the cabinets, look under all of the beds, and make sure that we got rid of everything. Because the first step was pretty general, right? Just a big sweep through the house, dumping it onto the lawn. So the last step is selective secretion. Yeah? And secretion goes that direction. But it's selecting in the house. So what it's going to do is primarily get rid of any cat box that you didn't find the first time. So it's going to get rid of wastes and excesses. What if I find another 50 cans of corn, right? I'm going to dump 50 cans of corn. If she's 85, she is not eating 800 cans of corn, right? So wastes and excesses. Does that make sense? Okay, so by the time you're done with this 3-step process, what you have done is cleansed the blood and very selectively left the good stuff in and gotten rid of the most of the bad stuff, right? And you didn't lose 47 gallons of water because what you did is you dumped out 47 gallons per day, but you reabsorbed about 46 and a half or 46 and 3/4 gallons per day. Does that make sense? Okay. All right, so filtration, reabsorption, and secretion is what we're going to do, and we can do it at the nephron. If you can't remember nephron, you can remember Zach. Nephron, okay? So you're going to do it at the nephron, and you can do these processes wherever the blood tubes and the P tubes are next to one another, yes? Okay, so we already know the blood flow, but we can see that wherever they're snuggled up against one another, you can have exchange between blood and urine. And we haven't done the uriniferous tubule yet. We haven't learned those structures yet. Note to self, what's going to happen is this starts where you remember, right? It's going to start here is, to orient yourself. Here's the arcuate artery. Here's the interlobular artery, right? So here we're up in the cortex, yeah? And we're dipping down into the medulla. Everybody good with that? Okay, so let's learn the structures that are involved in the tubular component of the nephron, okay? The tubular component of the nephron. In your notes, I color-coded it for you because people have a lot of trouble with figuring out which tube they're supposed to be in. So in your notes, the P tubes are always an unpleasant yellow color, right? And the blood tubes are always blood color, okay? And if you color code those, you'll be able to do a trace without ending up in the wrong place, Okay, so let's talk about this. The tubular component, also called the renal tubule, starts right here. So this is the first place right here. This yellow surrounding that ball of capillaries, the first place that you have anything that's going to become urine. Okay? All right, so I want you guys to follow this metaphor, and then I'm going to show you. So the capillaries we already learned. The capillaries are called what? The glomerulus or the glomerular capsule? Glomerulus, yes? So I want you to imagine this is that ball of capillaries, and I take that ball of capillaries and I push it into a softly blown up balloon, and I end up with a glove, right, of balloon, a space, and then another layer of balloon. Does that make sense? So when you look at that, what ends up happening is it's going to be surrounded by a capsule, yeah? And the capsule is here, and if you look at it up close, you're going to see that the capsule is completely surrounding it, but if you look at it even more closely, you will see that this capillary does not look like a capillary because it's got a glove on. Do you see? That glove is weird-looking cells because capillaries are made of simple squamous epithelium, and you should recognize them, right? But this doesn't look like that, and the reason it doesn't look like that is because here's the simple squamous epithelium capillary, and it's got a glove on, right? And the glove is really the inner layer of this capsule. They call it the visceral layer, space, parietal layer. Yeah? So, why? Because this is the site of filtration. This is going to be really high pressure blood that goes in there for reasons I'll explain in just a second. And then everything that gets pushed out gets caught between the visceral and the parietal layer, and it's going to end up making it into the toilet unless it gets reabsorbed. Does that make sense? Okay, so this is the first place that you are ever going to have anything that will end up in the urine. And it's not called the glomerulus because that's red and contains blood. It's called the glomerular capsule, right? Surrounding the glomerulus. Does that make sense? Okay, you can't use those terms interchangeably. It will screw you up both in anatomy and in phys if you can't keep those separate, right? Is that good? Okay, so the glomerulus and the glomerular capsule. So, now we are in the capsule right here. Collectively, by the way, I don't know why the hell they decided you needed another name, but this is the site of filtration in the nephrons, and collectively both the pitcher and the catcher, the glomerulus plus the capsule, are collectively called the renal corpuscle, and you can see those really easy on a histology slide of the kidney. Do you see that? The renal corpuscle? It's just this little ball that's got a white space around it. This is where the urine would be. Yeah? Right in there? That makes sense? Okay. It's actually not called urine until later for those of you who do phys, but nobody cares in anatomy right now. All right, so the glomerular capsule, we've got it. The space is going to be where you would first collect anything that ended up in the urine. And let's see why it's so good at filtration. There's 3 reasons why it's so good at filtration. First off, there are 1.3 million of these per kidney, so you've got a lot of surface area, right? Okay. Second, look how porous it is, right? The capillaries are fenestrated. Remember way back when we talked about fenestrated capillaries, I said you use fenestrated capillaries whenever you need transport but without losing control, like a sinusoid capillary, okay? So the capillaries are fenestrated, and then the visceral layer of Bowman's capsule, look, it's these weird looking cells called podocytes, but they've got slits between them, so even those are porous as well. So this is the inner layer of Bowman's capsule. That's kind of a cool picture of it. This one's even cooler because it's colorized. This is a scanning electron micrograph of the inner layer, like covering, right? So basically, I have a bunch of surface area, I'm very porous, and then one other little tweak. The other little tweak is simple plumbing. The afferent arteriole and the efferent arteriole. Look at the different diameters of the afferent and the efferent arteriole and tell me what it would do to pressure in this glomerulus. Big tube going in, small tube going out. What does that do to the pressure here? It increases, right? If you got a big tube coming in and a small tube coming out, right? You guys can do plumbing. Increases the pressure and therefore increases filtration. These guys, collectively, your 2 little kidneys, filter orders of magnitude more than all of the other capillaries in your body per day. The rest of your capillaries per day filter out about 1 gallon of fluid. Most of it's reabsorbed, right? These filter out 47 gallons per day. It's like an amazing amount that they are actually filtering. Okay, so now from there, we are going to start. So this is the site of filtration. So let's go back to our nephron. You ready? Okay. But now we are going to start doing the other two processes. And this is an oversimplification. If you're taking phys, it's going to get more complicated than this. But I'm going to simplify a little bit. And I'm going to say that most reabsorption is going to go on at the front end and most secretion is going to go on at the back end. So we already did filtration. Filtration happened from here to here. Okay. You guys tell me, filtration happens from what to what? Two structures. Glomerulus to glomerular capsule. Yes. Okay. So now I'm going to do reabsorption. And I'm going to reabsorb from what fluid into what fluid? Urine back into the bloodstream. Okay, so let's find the structures that I'm going to be working on. Okay, so as I'm going to be working on, here is the glomerular capsule. Anything gets dumped there ends up in what we call the proximal convoluted tubule, which literally means super curly little tube right next to the thing you were talking about, right? Proximal convoluted tubule. What happens primarily at the proximal convoluted tubule is a whole bunch of reabsorption, right? So I just dumped a bunch of stuff out onto the lawn, and now I'm going to collectively or selectively look through it and decide to pull it back into what? Do you remember what those capillaries are called that wrap around the tube? These guys up here. Peritubular capillaries, right? So I'm going to pull it back from the tube into the peritubular capillaries, right? So Bowman's capsule or glomerular capsule, proximal convoluted tubule, and then from the proximal convoluted tubule, depending on what kind of nephron I am, I can have a nephron loop, also called a loop of Henle. And what this does is goes down first and then back up. So you descend and then you ascend. What is going on in the nephron loop is primarily water reabsorption. That's primarily what's going on there is water reabsorption. So which of these two nephrons is going to be way better at water reabsorption? This one is going to be way better at water reabsorption. And you have some of each. Some are kind of specialized for doing other things. Some are specialized for water reabsorption. Now, if you were a desert animal, like a kangaroo rat, this would be as long as you could possibly make it, so that you lost very, very little fluid during the process of cleansing your blood. Does that make sense? Kangaroo rats have super duper long, like 6 times as long as humans, even their little bitty teeny kidneys. Really long nephron loops. Does that make sense? Okay, so I had glomerular capsule, proximal convoluted tubule loop, descending, ascending, right? Loop of Henle or nephron loop. And then I'm going to run into the distal convoluted tubule. And the distal convoluted tubule is further away, but it's convoluted as well, distal convoluted tubule. To oversimplify, most of what goes on at the distal convoluted tubule is secretion, right? So you look through the blood one last time and decide what you need to dump that you didn't catch the first time. Yes? Okay, now, when you're at the distal convoluted tubule, what that is going to do is that's your last shot, really, for exchange between the blood and the pee, because please note that when you get done with the distal convoluted tubule, you dump into the collecting duct. And is that surrounded by capillaries? No. So you really don't do much at the collecting duct with the exception of a little bit of osmosis that you don't actually need to do from the bloodstream. You can do from tissue fluid. Does that make sense? So do you see why it's called a collecting duct? Because it's collecting from multiple different nephrons? Yeah? And do you remember that when we looked at a kidney, we saw that these guys were striped, right? They look kind of striped. The reason they look like that is that all of the collecting ducts are sort of aiming down toward the bottom, and all of the urine is going to get collected in collecting ducts and then dump into what? What's this tip called? Renal papilla, which will get caught in the cup called the minor calyx. So, big picture understanding. Urine production starts where? In the cortex, right? Goes through the pyramid, yeah, and then gets dumped here. So urine production happens from the outside of the kidney toward the inside of the kidney, right? And then by the time you dump it in here, you can't really do anything else. It's already done, right? The urine production has already occurred. Is that good? So minor calyx, major calyx, then what is it called? Renal pelvis, right? Ureter, urinary bladder, urethra, toilet. Does that make sense? Okay, so collecting ducts collect from many different nephrons. Okay, so here is what students have trouble with, and I want you to make sure that you can think through. A lot of times, even in your lab manual, you had to do a blood trace through the kidney. But what happens with people is that because they know that there's two sets of tubes, they get confused as to which set of tubes they should be in. So for instance, if you're doing a blood trace, they start out really well in the renal artery, and then all of a sudden they end up in the proximal convoluted tubule. So if I were a red blood cell, should I end up in the proximal convoluted tubule? No, that's furniture. That should have stayed in the house. Does that make sense? Now, can it happen? Yeah, if somebody punches you in the kidney, it can happen, right? But it shouldn't happen, right? So if you are a red blood cell, you should go through and back out into the bloodstream. But what if you were urea, a waste product from protein metabolism? Then I would start in the renal artery. Stick with me for a second. Okay, let's do it together. You ready? So I'm going to trace urea from my bloodstream to the toilet. You ready? Okay, so if I trace urea from my bloodstream to the toilet, you have to think about structure-function relationships when you're doing this, okay? And to you, it might seem like rote memorization, but I promise it's not. It ends up being physiologically super-duper important to understand this. Okay, so you ready? So the urea would have ultimately come from the renal artery, right? Few steps, and then we're in the arcuate, right? And then we're into the interlobular. Then okay, you guys do it with me, right? From the interlobular, where do I go? I'm urea. I need to end up in the toilet. Afferent arteriole, and then glomerulus, and then what? That's when I make it out to the capsule, guys. I get pushed out into the capsule. Does that make sense? Okay, so it's basically like a cat box, and hopefully you caught it the first time. Right? So you went through the house and you've got waste products, right? And you need to dump them out onto the lawn, right? And all I have to do now is not bring it back into the house. Yes? So now I'm in the capsule. Now get me to the toilet. Ready? From the capsule to the proximal convoluted tubule to the nephron loop, descending then ascending. Then what? Distal convoluted tubule to the collecting duct, right? To the, let's do it. You guys can do it. Papilla, minor calyx, major calyx, renal pelvis, ureter, urinary bladder, urethra, toilet, right? So the conceptual understanding there is super duper important, okay? So I generally have you do something like that, either the whole thing or I'll leave spaces out of it, some kind of trace, blood or urine or both. Right? But as long as I'm specific about, like, it's a red blood cell or it's a molecule of urea, then you guys should be able to follow it. Does that make sense? Okay. If you can do that, it'll make your life in phys way easier too. Okay. So the vascular component of the nephron we've already done. We already talked about why the pressure is higher. Okay. So blood flow challenge, you guys can do that as well. I put a nephron on here for you so that you guys can color code it and label it. If you do that, it'll make it a little more comfortable when you have to do that stuff for your test. Is that okay? Okay. Now, one last little tidbit, and this is more phys, more P than A, but I want you to have met it before you get into physiology because it's kind of complicated. Okay. I don't ask you super duper complex questions about it, but I do ask you a little bit about it. You ready? Okay. There is this area where, let me show you. Do you see right here where the afferent arteriole and the efferent arteriole, and then what is lying between them is the distal convoluted tubule? Do you see that? Okay, so let me show you how that could occur. This one actually shows it. Afferent arteriole, efferent arteriole, distal convoluted tubule lying against that. Do you see? Okay, so what this area is right here is physiologically, it's a regulatory mechanism to help control the function of the kidney and to control blood pressure. And so what it is called is the Juxta glomerular apparatus. Why could that possibly make sense? Juxta glomerular. What does that mean? Next to the glomerulus. Yes? So the Juxta glomerular apparatus. Okay, I'm going to tell you that it does two things. So what it's going to do is it's going to monitor and respond to changes in blood pressure, and it's going to monitor and respond to changes in the solute concentration of the urine, okay? And you're going to do it in two different places, so stick with me, okay? We are going to have some cells in the wall of the afferent arteriole that are going to do one of those functions, and some cells in the wall of the distal convoluted tubule that's going to do the other. So what do you think the afferent arteriole cells are going to do? They're called juxtaglomerular cells in the wall of the afferent arteriole. They are going to monitor, you choose, blood pressure or chemical content of the urine. Blood pressure, right? That's a great place to monitor blood pressure, isn't it? Why is it better, for instance, to monitor blood pressure in the afferent arteriole than in the efferent? Because what's about to happen after the afferent arteriole? Something that is pressure dependent, which is filtration. So here's what happens, guys. If these guys detect low pressure, they will secrete a chemical called renin. And renin, what it actually will do is by several different mechanisms, it will raise your blood pressure. Does that make sense? Okay. So when you detect low pressure in the wall of the afferent arteriole, you'll secrete renin. My phys students know that it does it by causing vasoconstriction systemically and causing the release of a hormone called aldosterone. And for those of you who are not in phys, blah, 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 blah. Doesn't make any difference to you right now. Okay. And then right here in the wall of the distal convoluted tubule, you have some cells that are monitoring the chemical content of the urine. This is a great place to monitor the chemical content of the urine because you're almost finished being able to exchange when you're in the distal convoluted tubule, right? So what happens is that the distal convoluted tubule says, hey, I've got entirely too much glucose in here. It will send out a chemical that will increase glucose reabsorption upstream. Does that make sense? Or, hey, I don't have enough urea in here. It'll send out a chemical that causes urea secretion. Does that make sense? So this is the last check mechanism of the urine, is what it is, right? And those are so collectively, what is this called? Juxtaglomerular apparatus. Not easy to say or spell. Good? Okay. So the only thing I don't like about this picture is that you can't tell the difference from the afferent and efferent arteriole because they didn't draw them different diameters. But other than that, this region is the juxtaglomerular apparatus. Good? Go ahead.
Couldn't you tell that which one's afferent and efferent
because it's connected, right? It's lying up against the afferent. So in all likelihood, they meant for this one to be the afferent arteriole and that one to be the efferent. But if it was drawn a little wider, it would be easier to determine. But yeah, that's a good thought, Natalie. Okay, so done with the hard stuff, okay? The rest of it is really easy. Now we've made urine. We just basically have tubes and tanks on our way out, okay? So we've got the ureters, the urinary bladder, and the urethra. And then we'll talk about sex differences in the male and female urethra. So first, let's talk about the ureters. Since the kidneys start out retroperitoneal, the ureters do too, right? So they have to be back there with the kidney. The ureters leave on the medial surface at the hilus, right? That's where they leave. And they start out retroperitoneal and they run retroperitoneal until about the sacroiliac joint, and then they pop into the peritoneal cavity. Does that make sense? Okay. And they have to because the urinary bladder is in the peritoneal cavity, right? Or in the abdominal pelvic cavity, I should say. So they run into the abdominal pelvic cavity. And then the ureters actually go into the urinary bladder on the backside, right? They enter the urinary bladder on the backside. So if you flip it around, you can see they come in on the backside, right? Okay. So they average about 10 inches long. Of course, one of them is a little shorter than the other because the liver pushes your right kidney down, right? And they're average about 10 inches long, and it just changes based on your height. So, you know, I'm 5'2". Mine are probably not 10 inches long, right? But someone who's 6'4", probably they're more than 10 inches long. They don't vary dramatically differently in males and females, with the exception of just height difference in male and females. Unlike the urethra, of course, which is way longer in males than it is in females. Okay, so when you get the ureters, let's talk about what they're made of. So now is going to be the first time that you run into that tissue that is uniquely in the urinary system. Remember that epithelial tissue that is uniquely urinary? Transitional epithelium. You're going to run into it for the first time in the ureters, and it's going to be all the way through the ureters, lining the urinary bladder, and lining at least most of the urethra. Good? Okay, so if you look at the urinary bladder, let's look at it. The inner layer is a mucous membrane that's lined with transitional epithelium, right? and then it's going to have some connective tissue underneath it, and then it's going to have muscle. And the muscle is, oh, sorry, we were supposed to be in urethra. Sorry, I skipped to the urinary bladder. Didn't mean to do that. Okay, same story though. Lining the lumen is going to be transitional epithelium, then you're going to have some connective tissue, and then you're going to have smooth muscle in the wall, yeah? And the smooth muscle in the wall is going to be for peristalsis of urine. And I know it seems silly that you would have to move the urine by peristalsis, but you make urine constantly, even when you're not standing up, and you always need to move it from the kidneys to the urinary bladder. So you have to have the capacity for peristaltic contraction of the ureters. Does that make sense? So you've got peristaltic contraction of the ureters that moves it into here, regardless of your body position. Okay, so the ureters are going to have on their outside, they don't have serous membrane, they're all stuck to everything, so they've got adventitia instead of serosa. Okay, and then we are going to move into the urinary bladder. Okay, so as we move into the urinary bladder, what we're going to see is basically a really similar layers of tissue, but it's going to have way more muscle in it. The inner layer is transitional epithelium. Then we're going to have some connective tissue. Then we're going to have a really thick layer of muscle. And that really thick layer of muscle is several layers of, again, what kind of muscle tissue? Smooth muscle tissue. Collectively, it's called the detrusor muscle, so keep that in mind for just a second. And the detrusor muscle, when it contracts, it will allow you to void your bladder. And we'll talk about urination and voiding of the bladder in just a second. Okay, so let's talk about what else the urinary bladder does for you. Okay, so when you look at the urinary bladder, when it's empty, it's kind of a flat triangle. When it's full, it can store up to a pint of urine, and it extends upward into your abdominopelvic cavity. But let me show you where it actually is, because you may not have even noticed it on the cadavers, although they all have one. And the reason you might not have noticed it is because it's so stuck into the connective tissue at the bottom there that you don't even realize you're looking at the top surface of it. Does that make sense? It's not flopping around in there is what I mean. It's like stuck into the pelvic cavity with a whole bunch of connective tissue. So this is female, right? Urinary bladder, and that one's empty. And this is a male urinary bladder, and that one looks a little more full, right? So you're looking at the top surface right there, right? Okay, so with one other little thing. Please note, in a woman, well, in both sexes, it actually sort of pushes up against the pubic symphysis. Do you see that? But this ends up being really important and relevant when in a woman, because of course, look at the position of the uterus with reference to the urinary bladder. And when a woman is pregnant, is her urinary bladder going to be able to fill maximally and contain up to a pint of urine? So what happens is as the uterus gets bigger and bigger when you're pregnant, it actually pushes the urinary bladder against the pubic symphysis. And how often do you have to pee? Constantly, like all the time when you're pregnant, all the time, because it pushes it against the pubic symphysis. Does that make sense to you? Okay, now the interesting thing about this is that, at least in my experience, after you have the baby, you're still in the habit of responding to stretch in your urinary bladder with thinking that you have to pee. And it takes a while for you to retrain yourself to know that every single time you feel stretch, you are not going to have to pee. So I told my doctor after I had the baby, I was like, all right, it's been 3 weeks. Why do I still have to get up and pee 4 times a night? And he said, you don't. And I was like, what? And he said, you don't. You just need to retrain yourself to respond to that stretch by going back to sleep. And I'm like, but I'm pretty sure I'm going to pee the bed and I don't sleep by myself. So this is like, he's like, you just have to try it. So I told Mike, I was like, I'm going to try something. He's like, all right, I'm sleeping in the other room. No, he stayed with me. Okay, so now, people always say that they have small bladders. Generally speaking, the bladders are not super variable in size. What is super variable is how you respond to feeling your bladder being stretched, right? If you feel your bladder being stretched, it will send an impulse, we'll talk about it in detail a little bit later, to your pons, and then your pons will try to make you pee, but you can override that because the external sphincter is somatic controlled. But if you don't get used to overriding that, you are the person who thinks they have to pee every time you have a couple of tablespoons in your urinary bladder, and literally no one wants to go on a road trip with you at all. Hell no, right? If you ain't pregnant and you got to pee 5 times on the way to St. George, we are not hanging out at all. Okay, so not dramatically different sizes of urinary bladders in most people. Okay, so the internal anatomy of the urinary bladder, let's look at it. It has 3 openings. Please note that even though these attach way up here, they actually don't dump until you get down to the bottom of the bladder, right? So they look like they're going in on the top side, but they just run along the wall before they actually dump in. So you're looking at the anterior surface here, right? So here's your ureters coming in. You've got 2 openings for ureters and 1 opening for a urethra, right? And what happens is this creates a triangle called the urinary trigon. And the urinary trigon has some anatomic variability, just like everything else does. In some people, it's actually a little deeper than in other people. Unfortunately, that makes you more predisposed to recurring UTIs because it doesn't get cleansed and washed out as readily. So this anatomical variation in which your trigon might be a little deeper seems to predispose, especially women, to urinary tract infections. So let's just look briefly as we're talking about this as to why women get far more urinary tract infections than males. Ready? Okay, so if you look at a mid-sagittal section of a male versus a female, you can see, of course, that in a female, you only have about 1.5 inches or 4 centimeters of urethra to speak of anyway, right, before you get to your urinary bladder. And then the trigon was be on the backside right there. In addition, you have a lot of openings close to one another, right? You've got the urethra, the vagina, and then the rectum and anus back here, right? So obviously, if the little girl does not learn how to wipe properly, she is going to have a predisposition to urinary tract infections, right? You do not wipe up, right? You wipe back, right? And that's important to teach your little girls. But then in addition, just sexual activity increases your likelihood of urinary tract infections because other people are not sterile either, right? I mean, they might be sterile, but that's not what I mean. They do not have no bacteria. This versus this, right? So you have, on average, 8 inches of urethra before you get to the urinary bladder. I am not talking about an 8-inch penis. I was not born yesterday. I'm talking about the whole damn thing all the way up there, right? Including this part, right? So in addition, there are protective mechanisms on the male urethra in the distal end that actually have some secretory cells that help to lubricate, cleanse, get rid of pathogens because the male urethra, we know, has double duty. It has both urinary functionality and also reproductive functionality. So basically, we have just a barrier with how long it is, and then we also have some secretory protections. So males do not get anywhere near as many urinary tract infections. In addition, there's hardly any reason that you should have any overlap, right? You're not going to wipe all the way around here, right? With the same piece of toilet paper. You're not going to do it. And nobody has to tell you not to, right? You don't even need instructions about that. Okay, so the urinary trigon. If you see running in families, like my husband's family, all of the girls in his family have recurring UTIs. And of course, you know, we're friends now, so I can ask all of his sisters, so you guys know about wiping, right? And they're like, Mel, shut up. I was like, I was just checking. Anatomically, what I think is because his mother and all of his sisters have recurring UTIs, they probably just have an anatomically deep trigon, right? It's just deep and it never really gets cleansed very readily. So they have recurring UTIs all the time. Okay, tissue layers of the urinary bladder. The tissue layers of the urinary bladder we've already talked about, transitional epithelium, some connective tissue, some smooth muscle in the wall. How about innervation of the urinary bladder? It has both sensory and motor innervation. The sensory innervation primarily responds to stretch, and it's visceral sensory, right? And the motor innervation is autonomic. So think about this before you answer. Autonomic motor innervation, and I have sympathetic and parasympathetic. What do you think is going to, under normal circumstances, usually cause contraction of the detrusor muscle in the wall of the urinary bladder? Sympathetic or parasympathetic innervation? It's parasympathetic. I know we're in the habit of thinking, oh, I get scared and I pee. But if you get scared and you pee, it's not because of the sympathetic nervous system. It's actually because you lose control of that external urethral sphincter, which is skeletal muscle, which is not directly related to the sympathetic nervous system, but it is related to being scared. You're like, I got a lot of stuff happening, there's a tiger, oops, dribble. Okay? And we will see that you actually don't dump the contents of your urinary bladder. What you actually do is dribble out whatever was between your two sphincters. And we'll talk about that. Okay? So let's talk about the urethra. Okay? So, but blood supply, by the way. Blood supply is exactly what you would imagine. It's from the internal iliac arteries and drained by the internal iliac veins to going to the urinary bladder. Okay, so urethra. So the biggest anatomical difference in the urinary system between males and females is the urethra, right? The urethra is going to be way longer in males because, of course, it's going to go all the way from the urinary bladder to the tip of the penis for the external urethral orifice. And in females, it just goes from the urinary bladder 4 centimeters to the external urethral orifice. So first, let's talk about the sphincters. Okay, so there are 2 sets of sphincters in everybody's urinary system, and they're pretty much in the same places in males and females. First, at the bottom of the urinary bladder is the internal urethral sphincter, and it's smooth muscle, okay? And that one will have to open when we urinate, right? Does that make sense? Okay. And then this one right here, it's hard to tell where it is. I'll show you a different picture in just a second. This one, there's a floor of skeletal muscles holding all your junk in, right? And the urethra has to run through that floor, and there's a little sphincter that goes around the urethra as it runs through that floor. And that one's skeletal muscle. That one's voluntarily controlled. It's your potty training muscle. It's called the external urethral sphincter. So let me show you where it is in a mid-sagittal section so that you'll understand. At the bottom of the urinary bladder is where the internal is in both sexes. In what we call, this floor of muscles is called the urogenital diaphragm or the pubococcygeal muscles or the perineal muscles, but that's floor of skeletal muscles. So let's look at it mid-sagittal. Okay, here's female, okay? Even though it's not labeled, the internal urethral sphincter would be right there at the bottom, right, of the urinary bladder. And the external urethral sphincter would be right here in that floor of muscles, right? And in a male, same thing. Internal urethral sphincter would be right there above the prostate gland, right? External urethral sphincter is right there. Does that make sense? Okay. All right, so the internal urethral sphincter, its primary job is to prevent dribbling of what's stored in here into the urethra, right? Now, it slams shut. Sometimes there are a few drops in here, right? And if, for instance, your dog gets super duper excited to see you when you come in the door and he does a couple little squirts, he doesn't dump the entire contents of his urinary bladder. He squirts just a few little squirts if he loses control of his external urethral sphincter. Yes. And if you pee yourself when you get scared, that's probably what you're losing. It's just that little bit that was actually in the urethra between the internal and the external urethral sphincter. Go ahead.
Is it the same when people are like, oh, you're going to make me pee when you're laughing super hard?
Yes. Mm-hmm. Okay. Yeah. And also that happens way more after you've had a baby because it like rips the hell out of that whole birth control, all I'm saying, right? It's really good birth control. Rips the hell out of the whole thing, especially if you have a whole bunch of big-headed babies. My child had an enormous head. I was really glad that I actually had to have a C-section because I'm pretty sure nothing would work down there anymore. So he had like a blockhead. I think it had like square corners on it. Okay, so internal, external. So what is the urethra made of? What kind of tissues? Well, it's still in males and females. At the beginning, it's lined with transitional epithelium. But do you guys remember that toward the end in males, you have a different kind of tissue? Do you guys remember we only found it lining portions of the male urethra? Do you remember what it was? It was stratified columnar. Sometimes they call it pseudostratified columnar, but it's stratified columnar, really. I said pseudostratified in here, but I won't ask you about it. So it is a stratified columnar. It's not found in the female. It looks kind of pseudostratified, though. It's kind of weird looking. Okay, so, and it's only at the distal 1/3 of the male urethra. Okay, what else is lining the urethra? Same basic pattern. So you've got transitional epithelium, mostly, right? Then some connective tissue, and then some smooth muscle in the wall. And the smooth muscle, again, is for moving the urine via peristalsis. Males will have smooth muscle in the wall of the urethra all the way down to about the end, and then they don't have any smooth muscle. And in males, of course, it has double functionality. It, of course, is for peristalsis of urine, but it's also for ejaculation, the smooth muscle in the wall. Good? Okay. Females mostly don't ejaculate, but we'll talk about that in the next set of notes. We'll talk about female ejaculation and when it happens and what's going on there. Okay, so the external urethral sphincter is skeletal muscle. That's your potty training muscle. And usually it takes around the first 3 years of your life or so to get control of it completely. Males usually take a little longer. Most male anatomical and physiological development is slightly behind female, which kind of sucks for males because they also don't live as long. I'm like, I barely got all this crap down, and then you live like 7 years less than most females. So maybe that makes up for the 70 cents per hour that we get compared to their $1. I don't know. I don't know. Okay. So let's look at the sex differences in the urethra. So first thing is, of course, and you just, I know that I'm going to insult some of your intelligences, but we're an abstinence-only sex education state, so you would be shocked at how many people get it wrong on the 4th test when I ask how many openings females have here versus males. So let's make sure we can find them all and where they are in reference to one another. Urethra is the first one, the most anterior. Here's the clitoris. If you never found it before, you sure as hell will after we have a couple of lectures, okay? So, and it's on every single test. Don't think I'll let you pass that test without finding the clitoris, right? This is my public service. Okay, so this is the clitoris, but this is the urethra. This is the vagina, right? And this is the anus and the rectum, right? Now, which sex do you think typically does worse on this question, males or females? Females. Females are abysmal at their own knowledge of the female reproductive tract. It's amazing. And this is really, really important information because this, at a certain point during development, is partially to completely covered with a hymen. If you have 2 people with absolutely no education about the reproductive tract, you end up in medical journals by being one of those couples who tries to have sex, doesn't realize that there are 3 holes, and has sex through the urethra. Yes.
I don't know how that would happen. That would be the most painful situation.
It is outrageously painful, I imagine. The journal article that I just read on it said that the woman, neither the male nor the female, knew anything about reproductive anatomy and physiology, which is terrible. This is like abstinence-only education is just like, I would prefer to be dumb. So they both, neither one of them had any idea, and she had an imperforate hymen, which means it was relatively complete. So when she menstruated, because she only had little bitty holes, she would usually menstruate for about 3 weeks per month instead of 1, because it took a long time to get the tissue out. Does that make sense? So this was completely intact, and when they tried to have intercourse, it just wouldn't go in. And so just keep trying, and it went into the urethra. And they ended up going to the doctor for 2 reasons. A, she kept getting urinary tract infections for some reason, and she was becoming incontinent for some reason. And most importantly to this couple, she couldn't get pregnant for some reason. Because all the sperm were like, dude, I'm looking around. There's no eggs anywhere. No idea what the hell was going on. Poor little sperm. Okay, so males, of course, are going to have 2 openings. The external urethral orifice is here. Ain't nothing in the vicinity, right? Okay. External urethral orifice in females is right here. Every once in a while, by the way, the vagina can actually open. They can open into each other. It's a not uncommon anatomical variation. Okay, so in males, on average, the urethra is around 8 inches long, and there are 3 different sections of it. You ready? So females just have a urethra, right? That's it. Okay. Males have a prostatic urethra as it runs through the prostate. Membranous urethra as it runs through the skeletal muscle and the sphincters surrounding it, right? And then through here, it's the penile or spongy urethra, right? As it runs through the penis, right? Okay, so females is way, way easier. All right, so one of the things that I was happy to finally understand is that, of course, we know that the male urethra has double functionality. It's got urinary functionality and reproductive functionality. So it carries both urine and ejaculating semen, but there is a mechanism that in a healthy male will prevent them from being carried simultaneously. And it's primarily that as soon as a male becomes aroused, this internal urethral sphincter slams shut. It's one of the indications of arousal is that that slams shut. And then these glands, which we'll learn in detail in the next set of notes, called the bulbourethral glands, those will secrete a clear fluid that will change the pH of the urethra, cleanse all the urine out, right? And also lubricate the tip of the penis. So it's basically getting it ready for sexual reproduction function instead of urinary function. And in a healthy male, they won't be carried simultaneously. Urine and semen are not carried simultaneously. Yeah? Yes. Yes, and that's a fine question. Yes, exactly. Because if you are aroused, this will not open for you very readily. So even if you really, really had to urinate, you're going to have trouble getting it out of the tank. You can open this one, right? But this one's not going to come out, right? And does it also show you how prostatitis, inflamed prostate, causes problems with urination? Because it actually compresses the urethra. Does that make sense? Okay, so last thing on this set of notes, and then we'll start with the reproductive system, is the concept of micturition, and that's the fancy word for urination, okay? So micturition is really a sensory and motor feedback loop in which what happens is when the urinary bladder starts to get full, these stretch sensory receptors will tell that it's full. And what they do is they send that sensory information to the pons, yeah? And then the pons will try to send motor information out via the parasympathetic nervous system to cause contractions of some muscles and relaxation of others. So you guys tell me, in order to urinate, I would have to do what to the detrusor muscle? Contract it, but I would have to do what to the internal urethral sphincter? Relax it. Right? That's all controlled involuntarily. You, with your cerebral cortex, can control this one voluntarily. Okay? So what's going to happen is when you feel the need to urinate, the information goes to the pons tries to contract the wall, relax the internal urethral sphincter, and then you get to say, no, I'm in the middle of class, and contract the external urethral sphincter and say, not now, right? But the problem is that if your urinary bladder is still full, it's going to continue to send a signal. It's going to continue to go out. So you can do this for a little while, but it ain't going to work forever because eventually you're going to pee on yourself, right? There is only so long you can go without urinating. And some people can go a hell of a long time, but not forever, right? And the problem is that you never actually stop making urine. So your urinary bladder will just continue to fill and fill and fill. So you can decide it's okay, or you can inhibit voiding or urination. Go ahead.
So if you're sitting there holding it like in road trips or
yeah.
like on a plane when you're like, or in a gross bathroom. You're
yes. Like at a music festival, yeah. You're like, I will do anything not to have to go pee. That's why we bought an RV, because I'm not going anymore.
Will the bladder, once the bladder is full, will it start
backing up
into the ureters?
Yeah, into the ureters, yeah. And by the way, FYI, it's not super good for you to hold on to a waste product and wash it against an epithelial tissue for long periods of time as a habit, because you know that there are toxins in there that you were trying to get rid of, right? If you consistently wash those against this, you increase your lifetime risk of bladder cancer, which is a relatively rare cancer anyway, but you don't really need to do that, right, regularly. Right, road trips is fine, right? I don't like to pee in public bathrooms. The lighting is terrible. I go in there and I'm like, I thought I looked pretty this morning. I'm like, what the hell? You're like, how did I get out of the house like this? Ruins my whole damn day. But it's better than cancer. Go ahead.
So people go to the doctor and say they can't pee because it's due to the smooth muscle?
It could be due to any number of things. Usually with males, it's due to this little bastard right there. Okay, that starts getting inflamed. This is a really common site of persistent infections in males, like the trigon is in females, especially STIs. STIs, if you ever had one, they really like to hang out there and irritate your prostate, right? So we'll talk about prostate gland in the next set of notes. Okay, everybody good? Okay, so now we are going to start on the reproductive system, which is my very, very favorite.
I could tell with the 12 pages.
Well, nobody knows anything about it. I love it so much. It's so interesting.
I thought it was super interesting in lab. I asked a whole bunch of questions.
Yeah, and you're welcome to ask as many questions as you want, and I promise that I am not judging you, because half this stuff I didn't know, and I'm still in the process of educating myself. Note to self, note to you guys and to self, I'm trying to expand my knowledge, but there are still some things that I'm ignorant about. I've read tons of journal articles, and there's a bunch of stuff in here that isn't in your textbook. The first thing is that let's acknowledge that there's a difference between sex and gender, okay? And also, I'm going to acknowledge that I'm kind of bad about using them interchangeably, because when I was a kid, that's how we were taught. So sex has to do basically with your biology, yeah? And gender has to do, it's context dependent, right? And so what I'm going to tell you that I'm going to make every effort to use them appropriately, and will probably screw up. How did I figure out that I was screwing up? I was educated by one of my students who was transgender and told me that that is not the way that you use those terms. And so I went back and I figured out, okay, how do I use these terms? So I'm going to do my best, okay? So before we even get into the actual anatomy, I want to talk to you guys about how you became an anatomical sex at all. Like, how did you become male versus female, right? Or something that is not specifically male versus female, like an intersex situation. So let's start talking about that first. So first thing I need to tell you guys is that you started out with duct work, tubes, for both sexes, okay? So I want to talk about this. Okay, this is about weeks 5, 6 post-implantation, so like 6, 7 weeks after you had sex. Woman might not even know she's pregnant at this point, and we're talking about teeny little things, but still, the duct work is getting put in place, okay? So what you started out with, and everybody did, is double sets of duct works. Do you see the pink ducts over there? If those get supported in their continued development, they will end up becoming uterine tubes or fallopian tubes in a uterus, right? Okay? The purple ducts, if those get supported in their continued development, they will end up becoming the vas deferens and the seminal vesicles, right? And part of the male internal reproductive tract. But you started out with both, and everyone does. You with me? I'll tell you how you decide which side you're going to go on in just a second. Okay, so I want to look at the internal reproductive tract, and then I'll look at the external genitalia, okay? So do you know the term homologous? Do you know that term? Okay, for those of you who don't, homologous means same anatomical root. So for instance, my arm and a bird wing are homologous structures, right? Males and females have a lot of homologous structures, and one of them are your gonads are the same structure anatomically. The ovaries and the testes are the same anatomical structure that develop in different environments. So let's follow those first, and then we'll see how the internal reproductive tract actually forms, and then we'll figure out why it forms that way. Okay, so if this person were XX and normal typical development of an XX, what would happen is, do you see degeneration of the purple ducts? Yes? The purple ducts, by the way, the ones that are going to become male, are either called the Wolffian ducts, which is easy to remember because if I imagined a wolf to have a sex, it would be male. I mean, I'm not being sexist. I'm just trying to give you like an actual memory tool. Wolffian ducts or mesonephric ducts, which is hard to remember. The female ducts are Mullerian ducts or paramesonephric ducts. So if you were going to become a normal anatomical female, this is what your internal reproductive tract would do. You would degenerate the purple ducts, the Wolffian, right? And you would continue development of the pink ducts, which are the Mullerian. And then eventually that would develop into fallopian tubes or oviducts and a uterus. Everybody starts out with something that's kind of like a blind vagina. Everybody does. Males just actually develop mostly into urethra. Okay, now, if you were male, however, a normal, typical anatomical development of an XY fetus, what would happen is you would degenerate the female ducts, right, the pink ones, and you would continue support and development of the male ducts, the purple ones, and those would end up developing into the vas deferens and the seminal vesicles and give rise to a little bit of the prostate gland. Does that make sense? Okay, so what about these gonads? Gonads are the same structures. If you are female, they stay up in the abdominal pelvic cavity. And if you're male, they will differentiate into testes and eventually, not immediately, but eventually they'll drop through the inguinal canal. But they're the same structure. Does that make sense? Okay, so let's look at the external anatomy. Okay, do you guys know what the default anatomical sex in humans is? If you don't do anything, you will look like a what? Female, yes. Female is the default anatomical sex. I am not saying that you will be a fully functional, reproductively viable female, but the default anatomical sex in humans is female, and I'll show you why in just a little bit. So let's look at the external genitalia and see what these structures develop from. Again, we're about week 6 right here. In this picture, homologous structures are the same color, okay? So about the sexually indifferent stage, and then we're going to start development. And then you get to fully developed, right? This is when the primary sex characteristics are put down. So between weeks 12 and week 20, you really start this putting everything in place. Please note that the homologous structures in males and females are, note that the glands of the clitoris, the end of the clitoris, the head of the clitoris is homologous with the glands of the penis. Yes? And the labia minora, inner folds, are homologous with what? The skin surrounding the shaft of the penis. Does that make sense? Now, the erectile tissues in the shaft of the penis are a little different. I'll show you where those come from. Females have erectile tissues too. Okay, and then the labia majora are homologous with what? Scrotum, exactly, right. So we all started out with the capacity to become either anatomic sex. So now let's talk about how you end up being one, right? With normal reproductive development, how do you end up being one? So basically, until about 5 weeks of development, even if you did a sonogram, there wouldn't be a damn thing to see. First of all, it's super tiny. But second, you are not a sex until then. So nobody could tell you what sex the baby is, right? So if you're 5 weeks pregnant and they ask you if it's a boy or a girl, you can say yes, it is both, right? Okay. So the undifferentiated gonads will eventually become ovaries or testes, and they only drop through the inguinal canal about month 7, even though they already differentiated. They take a little while to drop through, and sometimes males are born without one of them dropped. Go ahead.
What set of notes are these? These aren't the ones that are on your website.
Oh, you don't have this one? Oh, okay, I'll just update it for you today. Okay. So what do yours look like? Let me see.
I printed this out yesterday.
Oh, I have those too.
Okay.
I think yours are actually more up to date than I thought mine were.
Okay.
So hold on, just wait right there. Is it this one?
Yes.
Okay, good. It's the same stuff. I just organized it so it was slightly easier to understand. And then I forgot that I did that. Good job, Mel.
Yeah.
Okay. All right, so now what we need to talk about is anatomic or biological sex determination. So how do you actually end up deciding one path versus the other? Well, you don't. The Y chromosome does. So what happens is at about 5-6 weeks gestation, there is a gene, well, it's always there, but there's a gene that becomes active only on the Y chromosome. And of course, males have a Y chromosome and females don't have a Y chromosome. This is called the Sry region, the Sry gene. And what it does, it initiates those undifferentiated gonads to start going down the testes path instead of the ovary path. Yes? Now, interestingly, part of the reason that males have nipples is because nipple differentiation happens before you actually had a sex. So nipple development happens before sex differentiation. So males end up with nipples because they didn't know yet whether they would need them. Go ahead.
So you're saying that though the organs haven't differentiated,
yes,
the genes will still have an X and Y chromosome from the beginning. So if you drew a DNA sample or something like that,
yes,
you would already be able to know the baby.
Yes. So as far as determinants of sex, if you are looking, and we'll talk about this in just a second, or actually probably next time. So what is it that are your determinants of sex? You've got several different things. You've got XX versus XY. That's your chromosomal sex, right? You've got your gonadal sex, which is whether they become testes or ovaries, right? But then you have your hormonal sex, which is, do you have a preponderance of estrogens or androgens, testosterone, right? Okay. And then you have your internal reproductive organs and your external genitalia. By the way, one of the reasons that someone may identify as transgender is if any of these do not agree with the others, okay? And we will talk about that, okay? All right, so now, so at about 5-6 weeks post-implantation, the Sry gene turns on, right? And it tells the undifferentiated gonads that you are on the path to becoming testes, right? And then, activated by the developing testes, you actually activate another hormone called MIH, and MIH is Mullerian inhibiting hormone that causes degeneration of the female ducts. Okay, so now do you see that in order to become an anatomically typical male, you have to flip 2 switches? Yes? Okay. Now, so what you would have to do is you would have to turn on SRY, start everything developing as testes, and then the testes have to turn on MIH, yeah, which degenerates the female. What if you flipped one of those switches but not the other? Can you understand that that's one of the ways that you could become intersex? Yes? And intersex means something specific. It means that your anatomy is neither anatomically typical male nor anatomically typical female, but something in between. Yes? And what do you think the chromosomal complement for most people who are intersex is? XX or XY? Most of them are XY. Yes? Can you see why that would be? Okay, so in a female, you're pretty much going to go down this path without much changing. Now, you might not become reproductively viable, but you're probably going to end up looking like this unless the Y chromosome turns on and tells you to develop the other way, right? So the default anatomic gender in humans is female, right? This is what you're going to do if you don't mess with it very much. You may not end up being functionally female, but you are going to end up female looking. So MIH hormone is activated by the developing testes, and it causes degeneration of the Mullerian ducts, stops the development of anything that could become a fallopian tube, uterus, or vagina. And it causes the testes to mature and descend, the labia to fuse and form a scrotum, and the clitoris to start on its way of becoming a penis. Right? So all of this is a 2-switch with males. Okay, so what we have figured out is that anatomic maleness is not the absence of estrogen, it's the presence of testosterone. Right? And how did we figure that out? Well, we did it both experimentally and then accidentally. If a woman decides that she wants to shoot herself up with testosterone because maybe she wants to build muscle mass, and she does it exactly the wrong point in development, you can flip the anatomic sex of a pregnancy. Now, are we going to end up having a baby that was supposed to be female and ends up being a functional male? No, what we're probably going to end up with is a baby that's intersex, and with which the clitoris develops something in between a clitoris and a penis, and the gonads are a little confused as to how they're supposed to behave. So if a pregnant woman is injected with testosterone at the right/wrong point in development, the XX fetus will develop something like an anatomic male. And then we have another, this one is actually a genetic mutation that shows us that sex differentiation is the presence of testosterone. And I'll tell you this one and then I'll let you guys go. So if you make testosterone, but your receptors for testosterone are malformed because of a genetic anomaly, right? So your testosterone receptors don't work, but you're making testosterone. What happens is an XY fetus will develop externally as an anatomic female. So what does this look like in the absence of large levels of testosterone? It looks like this, right? How about internally? Internally, what happens is MIH works, right? So you degenerate your fallopian tubes in your uterus, but you never actually turn on the rest of this. So what she ends up with is she ends up with a blind vagina, no uterus, external genitalia that looks female. And interestingly, and this is super duper interesting, these people have androgen insensitivity syndrome, and it tells us an awful lot about sex determination in the mind, because it seems as if their default mental gender is also female. So if they do not respond to that surge of testosterone 6 to 8 weeks in development, it seems as if most of us develop as mentally gender identifying as female. Now, they're going to be born, they're going to look like a little girl on the outside, you're going to name her Susie, you're not going to know a damn thing's wrong until she doesn't start menstruating, right, when she's 15 or 16. And then, what do? I mean, do you tell her that because she's XY, she needs to, for instance, in North Carolina, use the male bathroom? You do not. And by the way, she hits puberty and she starts to grow, and she actually starts to have breast development, because those of you who remember a little physiology know that if you don't use testosterone, it gets converted into estrogen. So she tends to be relatively tall, leggy, have large breasts, but she's not going to menstruate, and she is anatomically female and chromosomally male. That's androgen insensitivity. Okay? And just conceptually, does it make sense to you that that is a physiological condition that could be considered transgender? Yes? Does that mean that I understand all of the ways that a person could become transgender? I sure as hell don't. But I do understand that physiological example. Yeah? Okay. I will talk to you guys on Thursday. Sure.
So when you're talking about urine and you're talking about like some people can hold it and some people can't.
Uh-huh.
Is that the same for like